Uh, First of all, thanks to all who are attending this brown bag. I'm happy to see more and more people joining us. Today, it is my pleasure to introduce Dr. Rebecca Ashare. She's an associate professor in the Department of Psychology at UB. She received all of her training in psychology at UB and got her PhD in 2011. After she completed she did a pre-doctoral, clinical fellowship at Yale School of Medicine. And then in 2012, joined the Center for Interdisciplinary Research on Nicotine Addiction at the University of Pennsylvania School of Medicine as a postdoc. She was appointed to their faculty in 2012. Since that time, she's developed an interdisciplinary program of research dedicated to understanding substance use among individuals with psychiatric and medical comorbidities. This work has focused on three areas: mechanisms and outcomes of tobacco use among people with HIV, digital interventions for smoking cessation among individuals with serious mental illness, and the intersection of cannabis and opioid use for symptom management. She has been continuously funded by NIH since 2012, including serving as PI on 3 R01s, an Early Career K Award, and an R21. She has been the recipient of several early career awards and is an associate member of the American College of Neuropsychopharmacology. Lucky for us, after all those experiences, in 2021, Dr. Ashare was recruited back to UB, so she has returned to the Department of Psychology, and we're so happy to see her here. And I will turn it over to you, Rebecca.
Thank you, Lorraine, for that very nice introduction. And it is great to be here and presenting to all of you. In many ways, this feels like I'm coming home to Buffalo. And so it is good. It is nice to be back, but in a very different capacity as faculty. And so I'm new faculty here. I just started in August. And so what I'm hoping to do with this talk today is to present some of the work that I've been doing over the last 10 years and some more recent work in the hopes that it will identify some opportunities for collaboration and some new ideas. And I'm open to questions during the talk as well if they come up. So I'm going to be presenting kind of two arms of my research. The first is tobacco use in people living with HIV. And so this program of research began in, I think about 2011 or 2012, I'm sorry. Literally over a conversation at the water cooler in our kitchen where one of the investigators in our HIV prevention program said, a lot of our patients smoke. And, we are the Center for Interdisciplinary Research on Nicotine Addiction. That's where I was working at the time. And we said, well, let's look into this. And it turned out when we looked in the repository, about 3/4 of their patient sample smoked. And since that time, the program of research that we've built has really been a marriage between the Penn Center for AIDS Research and the Center for Interdisciplinary Research on Nicotine Addiction. And it is comprised of basic scientists, infectious disease physicians, clinical trialists, behavioral scientists, pharmacologists. And so it really, I think, embodies this very interdisciplinary approach that we take to science. Each person has a role and contributes to the broader goal of each project. And I think importantly, I actually also enjoy working with all of these people. And I think that that's an important component to this type of work. And it also lends itself well to multi-PI R01 grants. So you might be asking, well, why tobacco use and specifically people with HIV? Well, since the widespread use of antiretroviral therapy, that has substantially improved survival rates for people living with HIV. And that means that they are increasingly vulnerable to non-AIDS related diseases. And so therefore it makes it even more important to address modifiable risk factors like tobacco use. It's also an important priority by NIH. So a few years ago, the National Cancer Institute put out an RFA to specifically look at and improving smoking cessation interventions for people with HIV. And as part of this initiative, they funded 6 R01s and several R21s. And so this is clearly a priority at NIH as well. And part of the reason for that is because tobacco use among people with HIV is a significant health disparity. So we see that among the general population, we have done a tremendous job over the last 50 years of reducing tobacco smoking in the country. The national rate is about 14%. Among people with HIV, it's about 3 times as high, so it's about 42%. And in some pockets of the country, it's even higher than that. And if we look at this graph on the right here, so this graph is showing life expectancy for people with and without HIV and people who do and do not smoke. And we see these 2 lines right here. So people with HIV who don't smoke have about the same life expectancy as somebody who smokes but doesn't have HIV. However, if you're somebody who has HIV and you smoke, life expectancy is about 7 years lower than if you are a non-smoker of somebody with HIV. And so it contributes to significant life years lost. We also know that use of FDA-approved treatments for smoking cessation are significantly lower in people with HIV. I mean, they're low in the general population. Only about 10% of the general population use varenicline, which is our best-in-class smoking cessation medication. But recent data suggests only about 4% of people with HIV use it. Importantly, the treatments that we have are actually less effective in people with HIV. So when we look at cessation rates for nicotine replacement therapy, so things like the nicotine patch and the nicotine gum, about 30% of people without HIV will quit with those treatments. Only about 15% of people with HIV will quit with nicotine replacement therapy. And then these are data from a trial with a clinical trial, varenicline, that we recently published of people with HIV, where we showed that varenicline, or Chantix is the brand name, was actually more effective than placebo. So we see that at 12 weeks and at 18 weeks, the varenicline group had substantially higher quit rates than the placebo group. But by week 24, that difference disappears. And that's surprising to us because in the general population, the effectiveness of varenicline usually lasts out into 6 months. I'll also note that in the general population at week 12, we generally see quit rates of about 40%. So even when we look compared to the general population, varenicline appears to be a little bit less effective. And so the program of research that we've developed has really taken a 3-pronged approach to addressing tobacco use in people with HIV. So in the first, we're trying to understand the underlying risk factors. So in one of my ongoing R01s, we're trying to understand whether smokers with HIV are more vulnerable to known risk factors for smoking relapse. And this includes things like cognitive and affective factors. And we're also looking at biological factors like the nicotine metabolism, so how quickly people clear nicotine out from their system. I'm going to go into that in a little bit more detail. So those are some of the mechanisms that we're trying to study to understand why they smoke and why relapse rates are so high. And then I'm also a co-investigator on a couple of clinical trials looking to improve smoking cessation treatments. So one is a randomized controlled trial where we're trying to optimize treatments using this nicotine metabolism metric, as well as improving medication adherence. And we're also doing a trial in Botswana where we're using smartphones to deliver smoking cessation counseling to people with HIV. And the last component of this is addressing some of the adverse health consequences of tobacco use. And so in another ongoing R01, we are looking at the interaction between HIV and tobacco on inflammation and cognition. And so now what I'd like to do is talk a little bit about some of the work that we're doing around nicotine metabolism. So nicotine is metabolized by the CYP2A6 enzyme. It's a liver enzyme, and it is metabolized primarily into two metabolites, so 3-hydroxycotinine and cotinine. The ratio of those two metabolites are formed to what's known as the nicotine metabolite ratio, or the NMR. And the reason that this is important is because this biomarker is reflective of genetic variation in the CYP2A6 gene, and it also reflects environmental and demographic factors, so things like hormonal factors, gender, age, body mass index. It has strong test-retest reliability, and it's also related to several smoking phenotypes. So people who metabolize nicotine faster, so they clear nicotine out more quickly, tend to have higher levels of nicotine dependence. They tend to smoke more cigarettes and have a harder time quitting smoking. And importantly, a recent large multi-site clinical trial, in fact, UB was a site for this clinical trial, and my colleague in psychology, Larry Hawk, was the site PI at UB for this trial. So this was a trial of over 1,200 smokers where they were prospectively randomized based on their nicotine metabolite ratio to receive one of three treatments, either placebo, nicotine patch, or varenicline. And I'm just going to draw your attention to this leftmost panel here because the data are most stark there. So essentially what we see is that if you are a slow metabolizer, so it takes a long time for nicotine to clear out of your system, you do equally well in terms of quitting smoking, whether you're given the nicotine patch or varenicline, right? They're essentially no different. They're better than placebo, but they're not different from each other. If you're a normal or a fast metabolizer, the nicotine patch is no better than placebo, but you do pretty well on varenicline. So what this leads to is a treatment tailoring algorithm where essentially if you're a slow metabolizer, we would recommend that you use nicotine replacement therapy because it's over the counter and then there are fewer side effects. If you're a normal or fast metabolizer, we would recommend that you use varenicline. And this is important because we recently conducted a study where we compared the nicotine metabolite ratio in a group of smokers with HIV to a matched group of smokers without HIV. And we found that they actually metabolized nicotine faster. Now, this was, we can't derive any causality from this, but this was a very interesting finding to us because we wanted to understand what is contributing to this upregulation of CYP2A6 activity in these smokers. And so we started to look at some factors. We looked at things like CD4 count. We thought maybe if they had elevated levels of inflammation, that might be contributing. We saw no differences in CD4 count. We saw no differences in whether or not they had an undetectable viral load. Where we did see a difference was in a particular antiretroviral treatment called efavirenz. And the reason that we looked at efavirenz is because it is partially metabolized by the CYP2A6 enzyme. And so what we see here is that people taking efavirenz were significantly more likely to be a fast metabolizer. And so again, we can't make claims about causality here, but this did lead us to our next question. And so these are some preliminary data that were conducted by a fellow at Penn, Cedric Bingund, where we looked at paired samples of 89 patients with HIV from the Center for AIDS Research repository. And the sample on the left here is when they were viremic and not taking any ART. And the sample on the right here is after viral suppression when they're on ART. And it stands out pretty stark here that the folks who are taking an efavirenz-based antiretroviral therapy have a significantly higher nicotine metabolite ratio. So this gave us more confidence that this particular ART may be contributing to the effect that we were observing. And also suggests that we should be investigating whether other antiretroviral therapies may be contributing to this upregulation of nicotine metabolism, because that can make it harder for people to quit smoking. And so we're following, so this is my colleague, Robert Gross at Penn. And so this is an ongoing R01 where we are addressing several questions related to nicotine metabolism. So the first is, does the HIV infection itself, so does the inflammation caused by the infection somehow cause this upregulation? And so we have samples from pre and post-infection, and so we're investigating whether that contributes to a change in NMR. And then we're also looking more broadly at different antiretroviral therapies to see what effect they have on nicotine metabolism, and to see if we can pull out specific ARTs, because if we know that some ARTs might be upregulating nicotine metabolism, this might be clinically important information, because we could recommend to patients who smoke that they move off of the ones that we know upregulate nicotine metabolism and onto ARTs that we know don't. We are also looking at what impact higher nicotine metabolite ratio has on the ability to quit smoking in this study. And lastly, we are looking at how the nicotine metabolite ratio can increase risk for other complications. Specifically, we're looking at myocardial infarction and whether the nicotine metabolite ratio is predictive of the likelihood of somebody experiencing an MI. And so that's an ongoing study where we're using several national cohort studies that have been collecting samples from thousands of patients for many years now. And then, as I mentioned before, one of my ongoing R01s is investigating whether smokers with HIV are more vulnerable to known risk factors for smoking relapse. And if we take a closer look at HIV-related risk factors, HIV-related comorbidities, and we look at something like psychiatric and neurocognitive function, these can sort of shed light on some of these issues. We know that the rates of psychiatric comorbidity are higher among people with HIV. And we also know that despite antiretroviral therapy reducing the incidence and the severity of HIV-associated neurocognitive disorders, they're still highly prevalent. So somewhere between 40 and 70% of people with HIV still exhibit some deficits in multiple cognitive domains. And these, even though these cognitive deficits might be subtle, they can contribute to functional impairment. So things like unemployment, difficulty with medication adherence, and importantly, smoking can accelerate the incidence and the progression of HAND. And we're focusing specifically on mood and cognition here because nicotine withdrawal, we know, increases mood disturbance and increases deficits in cognitive function. We also know that the domains of cognitive function that are impaired during abstinence are very similar to those that are observed in HIV-associated neurocognitive disorder. So things like working memory, processing speed, and attention. And importantly, those who experience the greatest mood disturbance and cognitive deficits are also more likely to relapse. And so if people with HIV are already experiencing higher rates of mood disturbance and cognitive deficits, they may be at greater risk for relapse. And so we did a preliminary study a few years ago just to better understand cognitive differences in cognitive function between people with and without HIV. And we had two groups of smokers, and because they were drawn from two different samples, the groups differed on some other characteristics like education and nicotine dependence and age. And so we were interested in whether the differences that we were observing in neurocognitive function were actually unique differences between the groups, or whether we were accounting for other sociodemographic characteristics. And so we did an analysis where we looked at exactly that question. And so we included in a model where we were predicting HIV status, and we included our demographic and our smoking variables. And when we did that, we did pretty well. So that's this red line here. So we included education and nicotine dependence, and we accounted for about 70% area under the curve. We included just those two variables. But when we added our variables of neurocognitive performance, accuracy, response time, and intra-individual variability, which is thought to reflect an index of sustained attention, our area under the curve jumps to about 85%. And the difference between these two curves was significant, suggesting that we did account for some significant and unique variance with our neurocognitive variables. And so we do think that these are important factors. And my R01 that is ongoing, it's a mechanistic observational trial, and we'll be wrapping up recruitment sometime in December. And so we are excited to kind of dig into those data and see what patterns are showing up there. And I think importantly, that study will also tell us, because we're following people, it's a smoking cessation study, we're following people, we'll be able to link things like cognitive and affective variables to quit outcomes and evaluate whether they differ between people with and without HIV. So now I'm going to sort of do a 180 and kind of switch gears here a little bit. If it's okay, I'll just keep going unless people have burning questions about HIV and tobacco use. But if not, I'll just keep going with the next portion. Okay.
I think you can keep going.
Okay. So the next sort of arm of my research that I wanted to talk about today is a newer line of research for me that I've been working on for about a year and a half, related to cannabis use in cancer patients. And I'm excited to present this today because I know that Lorraine put out the call to the other folks that are part of the Cannabis Center. So hopefully this will also, spark some ideas for collaboration. For the past year and a half, Brooke Worcester and Salima Magani have been the two primary collaborators in this space. Brooke's a palliative care physician at Thomas Jefferson University in Philadelphia. And she is also the director of their master's program in medical cannabis science and business. So they have a program specifically focused on cannabis certification and education. And Salima is a professor in the nursing school at Penn, and her expertise is in cancer pain and opioid use, and specifically looking at racial disparities in cancer pain and opioid use. And over the past year and a half, we've been working on several studies. We've done some surveys of clinicians and surveys of patients. We've begun to look at some of these questions as how cannabis might be related to racial disparities in pain management, as well as just generally self-reported symptoms and quality of life among people who use medical cannabis. So the first study that we did was a statewide survey of clinicians. So this included physicians, nurse practitioners, pharmacists, and physician's assistants across the state of Pennsylvania. And we asked them about their attitudes about cannabis, what kind of training they'd received, and any experiences they'd had. I will say one of the things that stood out to us is that very few clinicians reported feeling comfortable discussing dosing and treatment plans with their patients. But in general, about 3/4 said that they would recommend cannabis to a patient. Only about half said they had any formal training, but the vast majority of people, almost all actually, said that they would be willing to receive more training and that they would like to have more training. In Pennsylvania, and I'm assuming it's the same in New York, only physicians can certify patients for medical cannabis. And so of the physicians who responded to the survey, 85% said they were currently certifying patients. And this was a little bit surprising to us because about 70% of the clinicians reported that they recorded cannabis use in the electronic medical record. And this was surprising to us because we didn't think that this was as common a practice as it is. It's mostly done in the notes section, which is anybody who's ever done work in an electronic medical record or tried to do research within EMR is actually not very helpful for tracking or for follow-up. So for the next person, so for the next clinician who sees that patient, it's actually not very helpful. And so one of the things that I think my colleague Brooke is working very hard on is getting some changes pushed through to electronic medical records to make it a specific field to document this type of information. This next number kind of blew us away a little bit too, was that about 2/3 of clinicians said that they get their information about cannabis from their patients. And so, which, is not that surprising given that the lack of education that clinicians are receiving. But this number was even higher among physicians. So physicians, about 78% of them said that they get their information about cannabis from their patients. So it's clear that, clinicians are, they're feeling like they would recommend cannabis, but they don't know enough about how to recommend dosing and treatment plans. And so they're not feeling particularly comfortable, but it's clear that patients want to be using cannabis. And so the next study that we did was a survey of patients. And so we recruited people from dispensaries around Pennsylvania for a 12-month longitudinal study. So the data that I'm going to show you are the baseline data for this. And excuse me, I will mention that in this particular sample, polypharmacy is relatively common. So about half the sample are taking either benzodiazepine, an opioid, or some other type of sedative in addition to using medical cannabis. These were the most common certifying conditions. So pain was the most common, which is not very surprising. I mean, you see that throughout the literature that pain is the most common one. What is interesting here is that about 1/3 of the sample reported that they, or not reported, this was from the state database, were certified for anxiety. Now, this is interesting because Pennsylvania is actually only one of 6 states where anxiety is specifically listed as a certifying condition for medical cannabis. And this is also interesting because the evidence about the effectiveness for cannabis on anxiety is very mixed. So there are studies showing that the long-term, that, in the short term, the acute effects of cannabis on anxiety may be beneficial, but that the long-term effects may actually be harmful, and it may depend on the type of anxiety. So there are very mixed data about the effectiveness on anxiety. So as researchers, I think it'll be good for us to keep tracking this and to keep an eye on what's happening here with this. These are the most common symptoms that people reported using cannabis for. So anxiety was actually the most common, so not pain. So 65% reported using cannabis to reduce anxiety. Pain was the next, and then sleep and depression. And so again, when we look at the broader literature, of these 4 symptoms listed here, pain is really the only one where there's evidence to suggest that cannabis is effective. there are some data that suggests that it is effective for sleep, but for every paper there's another paper that says it's not effective for sleep. So these data are really mixed, and I think it just goes to show that the research in the effectiveness of cannabis for symptom management is really at the early stages, and we really need to be doing more rigorous research in this space. We did look at self-reported change in symptoms. So just the perception that cannabis is reducing their symptoms. And what we see here is the overwhelming majority. So this is the percentage of people who reported a slight increase or a moderate decrease. 90% or more of people reported that cannabis either slightly decreased or moderately decreased all 4 of these symptoms, right? So I think, and again, that there's some selection bias in this sample, right? We recruited people from the dispensaries, but there is this perception that people are deriving benefit from cannabis for these particular symptoms. But as I mentioned earlier, and my colleagues and I are particularly interested in cannabis use for cancer patients. And so as part of this work, we are conducting a study, a survey of the prevalence and the perceptions of cannabis use in cancer patients. So we're looking at their beliefs about the benefits, the risks, attitudes towards use, types of conversations they have with their providers. And this is a supplement that was funded by the National Cancer Institute through the Abramson Cancer Center at the University of Pennsylvania. And the NCI funded 13 sites to do this supplement. And our site is seeking to have about 1,000 people respond to this survey. And there are some core data elements across each of the sites. So when all of these data are collected, these 13 sites are going to compile a really large representative data set of what cannabis use in cancer patients currently looks like in this country. And I think importantly, there are sites around the country where even medical cannabis isn't approved. So there's a site at Medical University in MUSC in Charleston, South Carolina, where they're not even allowed to use medical cannabis. It's not legal there. And so we will have different snapshots of differences in policy across the nation and how that impacts cannabis use and perceptions and so on. So these are all patients. So this is an ongoing survey. So I just want to mention that. So these are preliminary data. Excuse me. At the time that I did the data poll, we had about 245 people who responded to the survey. So these are preliminary, but I did want to share just some of the trends that we're seeing. And so far, the sample is about 66% female, which I think tracks with what we would expect to see from our cancer patient population. 86% white, which reflects the patient population at the Abramson Cancer Center, but does not reflect the population of Philadelphia. And so that's something that will need to be addressed in our survey. And so far, about 37% have said that they've used cannabis since their diagnosis. And since these are patients who have been diagnosed in the last year, they've used cannabis fairly recently. So they've used cannabis within the last year. Of those, about 56 said that they're currently using cannabis. And when we looked at the frequency of use, what stood out to me was about a quarter are using it every day. Right, so there are a significant portion of people who are using cannabis every day. And there are certainly a good portion of people who, only used it a couple of days in the last. So this is, the number of days that they used in the last 30 days. They've only used it a few times, but a significant portion are using very frequently. Coming back to the survey that we did with clinicians, so we were also interested in what types of conversations patients are having with their providers and what they would like to be talking about with their providers. Only about a quarter of the population said that they talked with their healthcare provider about cannabis. And only 9% said that they got instructions on how to use cannabis from their healthcare provider. The vast majority of folks said they either got it from staff at the dispensary or from a family member or a friend. So, and this is just, it's consistent with the survey that we did with clinicians, showing that clinicians are getting their information from patients. Patients are not getting their information from their clinicians. And then this number right here is probably relevant for New York. About 36% said they'd be more likely to use cannabis if it were legalized for adult use. So, just to keep in mind, so the people who completed the survey never had to use cannabis in their life to complete the survey, right? Because we're also just interested in just general beliefs. So these are folks, so some of these folks have never used cannabis in their lives. And so the notion that legalizing adult use would suggest about a third of the sample would be more likely to use, I think is notable. And then, another question that often comes up is, well, how are people using cannabis? And so what we see is, between smoking and vaping, it's about 28% are either smoking or vaping. And then another 35% are taking it orally. So they're either using edibles or taking by mouth. This could be a pill or it could be like a tincture. So most folks are using one of those four ways of using cannabis. And then, again, we're interested in what people believe are the benefits of cannabis use. And as I just mentioned, folks did not have to be cannabis users to complete this survey. They could have never used it in their lives. And across the board, 92% of respondents said that they believed there was at least some benefit to using cannabis. And when we look more specifically at individual benefits, see between 80 and 90% of people say that cannabis is beneficial for pain. So the dark blue bar are patients who are not using cannabis, and the light blue is patients who are. And the same for stress and anxiety, so between 80 and a little over 90%. And these differences are not significant from each other in terms of the difference between the groups. Where we do start to see a little separation is for sleep. So people who are using cannabis believe that cannabis is more beneficial for sleep than who aren't using cannabis. And then this is another area, excuse me. This is another area that we're very interested in. About half of the patients who are using cannabis also reported that cannabis enabled them to decrease their use of other medications. And this is important specifically for cancer patients because cancer patients with pain are often prescribed opioids for pain. And so that the intersection of cannabis use and opioids for cancer-related pain is another area of research that we have begun. And I'm going to jump right to here. So I think it's pretty safe to say we know that cancer patients are using cannabis for symptom management. And it's possible that this could have an impact on opioid use. And this is a quote from a qualitative study that my colleague Salima Magani did, where the patient said, "I'll first go to the marijuana, and if that doesn't work, I'll go to the harder medicines. Rather than take OxyContin and hydrocodone, I'm taking the marijuana strands." And so this suggests that people may be using cannabis to titrate their use of opioids. There's some data to suggest that that's true, but there's not a lot of longitudinal prospective data out there on this. And the other thing that we know about cancer pain is that there are significant racial disparities in cancer pain management. So Salima is a national leader in this area, and her work over the last 15 years has shown that Black patients with cancer experience higher pain severity and lower pain relief. They're less likely to be prescribed opioids. And so we're also interested in what role cannabis might be playing in these disparities in cancer pain management. And so we used some data from Salima's ongoing longitudinal study of outcomes of opioid therapy among Black and white patients with cancer. And we used an item from the brief pain inventory called least pain. And essentially what it does is it asks patients to rate what their pain was at the lowest pain that there was over the last 24 hours. And it's a clinically meaningful index of pain relief, where a higher score on this least pain item reflects less pain relief. And so what we see here, and so here the race by cannabis use interaction was significant. What we see is that among people who were not using cannabis, we see that Black patients with cancer reported higher least pain scores, indicating less pain relief than white patients. Among people who were using cannabis, this difference decreased. And so, again, these are preliminary data, but we are, we believe that these warrant additional follow-up given the disparities in cancer pain relief and also in cannabis use between Black and white patients. And so in terms of future directions for this work and my work in general, so actually in collaboration with some folks here at Roswell Park Cancer Institute, doctors Amy Case and Danielle Smith, sorry, I merged their two names, and my colleagues at Jefferson at Penn, we're hoping to do a much larger longitudinal prospective study looking at the intersection of cannabis and opioid use on cancer-related pain. I think, bringing in some of my work in HIV, looking at HIV-related pain and cannabis use and its impact on HIV-related inflammation. I think there's opportunities there as well. Some of the mHealth work that we're doing, I didn't really talk, didn't talk too much about this, but we are also doing a study where we're developing an mHealth app that will provide cannabis education to patients. And so we are developing the app and plan to do a pilot feasibility study of that app in the spring. And then just generally, as I mentioned before, looking at the impact of cannabis on other symptoms, given how mixed some of the data are, showing effectiveness first, in one realm, and showing that, long-term outcomes might be different versus short-term outcomes, that I think it's going to be important to understand why we're seeing some of those differences in the literature and to really do some more rigorous research to try to hone in on what's really happening there. And I think I have some time for questions. These are my acknowledgements, and I'm happy to take any questions. Thank you for listening.
So thank you very, very much for that interesting talk. One thing that can help with the questions is if you stop sharing your slides so then folks can see each other. The Cannabis part of the talk was personally very interesting, but I learned a lot about HIV and smoking, which was new to me. So again, I really appreciate that. Time for questions. Okay, Lynn, please go ahead.
So I sent some questions to Jen.
I was gonna say, I have them.
Pardon me?
I have them, but go for it.
Yeah, they relate to the tobacco use. It turns out that Becky and I collaborated on a paper many years ago with Andrew Strasser. So
yes.
hi, Becky, we'd never met before.
No, but I have heard many, many, many good things about you from Andrew. Andrew's a wonderful colleague.
Well, that may change once you hear my questions. Some evidence argues that some smokers may be self-medicating with nicotine to
Mhm.
enhance cognitive performance. Is that a possibility in HIV individuals with cognitive deficits?
I think it is a possibility that that the nicotine itself may be contributing to some of the, maybe alleviating some of those cognitive deficits. And so that is one of the things that maintains it. One of the other RO1s that I actually didn't really talk much about, but we're actually investigating the role of cholinergic function in HIV on cognitive function. So we're trying to look more specifically at that question. But yes, that's definitely a possibility.
So I have one other question, somewhat related. Any thoughts on the possible advantages of HIV smokers switching to nicotine vaping as an ongoing substitute for cigarette smoking?
So I always hesitate to jump into the vaping debate because I know that people tend to fall very hard on like one side or the other.
I know you work with Frank Leone on some points, and he is very much negative about that. Actually,
very much, yeah.
Let me make a comment about vaping related lung disease that Frank Leone's big on, so-called E-Valley, the CDC has talked about.
Yes.
Recently, several of us, I'll mention some names, Ken Warner, Dave Abrams, Mike Cummings, me, about 10 others have submitted a request to the CDC to stop calling E-Valley, the vaping related lung disease, E-Valley, because by and large, the preponderance of the evidence is that that was due not to nicotine vaping, but to black market cannabis vaping.
Right,
so
yes,
I
yes.
think the field's got to get it straight that people, CDC has been wretched. It's been using E-Valley as a flag to say, don't vape anything, don't vape anything. It might cause lung disease. And I'm telling you, some of the major people in the field have looked closely at this evidence, and the evidence sucks that nicotine vaping causes E-Valley. But the evidence is wonderful that black market vaping of cannabis is something by all means you better avoid. I would say black market vaping of anything. You should.
I would agree. Yes, I would agree with black market vaping of anything. Yes. Yeah, no, and I have seen Frank go off on his when Frank gets going talking about his about vaping as well. But yeah, I don't, I think that to the extent that it's, if we were in the UK, right, you can be prescribed vaping to quit smoking, right? It's an approved treatment for smoking.
Their quit lines would recommend it to people.
That's right. Yeah.
I'm done. Nice to meet you.
It's nice to meet you too. Thank you. Thank you for your questions.
So I have a question, and it shows up a lot in the research where people just refer to cannabis use. And there's no stipulation of what that involves. So we know dose is huge. For example, in anxiety, if you're using 95% THC, it's going to be very different than if you're using 15% THC. You did look at mode and the whole issue of THC to CBD ratio. There's so many variables. How do you get a handle on that? Or do you just kind of use the generic cannabis use? Because when I hear these kinds of data, I'm like, so what are they using? That's my first question.
Well, you should talk to my colleague, to Brooke Worcester, because that's also a thing that she drives, like, because, and she's developed some collaborations with dispensaries in order to, where she gets data from the dispensaries on what people are actually using to get a better sense of that question. Because I think what people have found, and I think I see that Amy Case is on, I don't know if she's still on, but I think Amy could probably also relay the fact that people don't often know what they're using, right? And so if you ask, and so we actually do have a question in our cancer patient survey about, we're not asking about we're just asking, is it THC predominant? Is it CBD dominant, or is it a balanced ratio? And a lot of people check the box that they don't know, right? And I think particularly if you're not getting it from a dispensary, if you're getting it from a family member or a friend or your local buddy on the street, like you often don't know what's in it. So that makes it really challenging. I don't know that I have a good answer to that, except to say that it's very challenging, and we're trying to glean some of these questions as best we can. Asking people to, if they're getting something from the dispensary, can you save the box and show us, that type of thing. But, that doesn't always work.
Thank you. It is very frustrating when you try to do cannabis research.
It is.
Are there any other questions? We've heard a really interesting talk. So, Jennifer, do you have any other? I see N. Bartman, please.
Sorry, I'm Nate. I can't get my thing to change my name, sorry. But kind of a piggyback on like the mode and the dosage of cannabis, and kind of if there's wondering if there's any push to kind of get practitioners to be working in like a kind of a pharmacy sense with the dispensaries. Unfortunately, I saw firsthand, my wife had cancer and she was treated at Roswell Park. And so she had that conversation with the oncologist about cannabis. So it came from her, and the doctor said, yeah, there's nothing wrong with doing it, so go ahead. But she was at the kind of the mercy of the dispensary and what they suggested.
Mm-hmm.
And at one point she said that she told her hospice nurse that cannabis was the only thing that was touching her symptoms, towards the end. So it seemed like it was very, very powerful in some ways to help her, but she was also overwhelmed by, what do I choose, liquids and types, and does the person at the dispensary even know what they're talking about, that sort of thing.
Yeah, no, thank you for that question, and for sharing your story about your wife too. I think it's a good question. I think one of the things that Brooke will often tell her patients is seek out the pharmacist when you go to the dispensary, because there should always be a pharmacist at the dispensary, because the floor staff might be motivated to sell you what's on special that week, and may not necessarily be the strain that's most appropriate for you, based on your needs. But I think that it's still a question as to how that then links back to the physician, as you said, like, how the physicians get that information back, because nothing's linked to the medical records, nothing, there's no correspondence there. So there's a break in that chain that, I think needs to be fixed if it's going to be part of care.
Yeah, because it seems like it can, and it just seemed like such a shot in the dark for something that was possibly so helpful, and at times really was.
Right.
Thank you.
Thank you.
We do have a question from Sierra Lieber, kind of goes to the topic you were just talking about. How does cannabis use in chronic pain in a non-cancerous context work, specifically related to autoimmune diseases?
That's a good question. So I don't know specifically about autoimmune diseases, but I know that in general, pain, chronic pain is one of the most robust areas where cannabis has shown to be effective. So just across the board, I think probably less so for things like neuropathic pain. But in general, for pain, cannabis is, the evidence is pretty good that cannabis can be effective. Ben, do you have a question?
I do. I guess just I thought it was really interesting in the presentation how like the only thing that is consistent that cannabis is good for is pain management, like we're talking about. And then I guess I just kind of kept thinking about it, especially with the question that Jennifer just asked. Is there certain types of pain that it works for, or does it work for like all pain? Like, could I take it for migraines compared to like, a knee injury? Like, would it be just as efficient with, I guess, different types of pain? It was a question that I had.
Yeah, that's a good question. I don't actually know the literature too well on migraine pain and cannabis. I don't know if anybody else, Lorraine or I don't know specifically about that. I do know that I don't think it's as effective for things like neuropathic, peripheral type pain, that it's more effective for, things like back pain and cancer related pain, that type of, but so I would have to look into that to know more specifically about the types of pain. That's a good question though.
So one of the things that we face is the number of studies, the quality of the research on cannabis and pain, and cannabis in every health condition
Mhm.
is way, way behind use. And by the way, and I know this because I teach a cannabis course at UB, the pharmacists know almost nothing, even if they're working in a dispensary. So the training is minimal.
Mhm.
And among the students who were in our cannabis course, they are so hungry for knowledge. They kind of jump through hoops to get into the course because they know that it's happening. They know that there is this kind of new employment opportunity, but there's no training. And
Yeah.
so, it was kind of interesting that you say the healthcare workers are getting their information from the patients.
Mhm.
The patients are getting their information from online, from all sorts of questionable sources. Let's not forget where medical cannabis in the US started. It was with a proposition in California where the population voted. There was no scientific evidence presented, and the win was maybe 1 or 2%. So the whole thing is just built on a very, very shaky foundation. Lynn.
I did not know that.
So I think it's interesting that if you go back in the history of tobacco use, when tobacco was introduced to Europe, for years it was thought to be a cure-all. It would cure anything, all diseases. It was a panacea. And I think there's a kind of parallel with some of the hype around cannabis that does all these things. The reality is it probably only does some of them.
That's true. Yes, I think that's right.
Okay, well, I know we could keep this discussion going for hours, or at least I would. But anyway, thank you so, so much, Becky. That was a great presentation. And as you may have noticed, she's under the weather and still.
I'm just grateful I didn't cough through half of it, but but thank you so much for having me. It was great to present. You can, if you have any follow-up questions, please feel free to reach out and email me. I'm happy to talk to folks.
All right, and thank all of you who attended. We really appreciate your getting us started with attending this talk, and look forward to other talks. Some of them are going to be job talks in CHHB that will be coming your way. So again, thank you very much. What a great talk. Bye-bye.
Thanks,
Thank
Becky.
you.
That's great.
All right, thanks. Bye-bye.